Hello everyone. Thanks for joining me today. I really appreciate that you come and join me today. Uh, uh, I think there's not many of us today, so I think we can even do question and answer session at the end if you want. So the reason I do teaching is because I'm passionate about the subject of cardiology, and I would love to teach from the basic and also the fundamental of cardiology in order for you to understand the topic. So what we are doing today, and I think we did understanding of prosthetic aortic valve just now. So now we're going to go to prosthetic mitral valve, okay? So basically the approach is the same as prosthetic aortic valve, i.e. whenever you look at the echocardiogram, number one, look at the 2D images first and see whether you can see any abnormalities. Is there any obvious regurgitation that you can see? Okay, and then after that, as opposed to prosthetic aortic valve, where you look at the velocity first. So if its velocity is more than 3 meters per second, then you start to think what is the type of dysfunction that you're looking at. In prosthetic mitral valve, there is no hard and fast rule, but I would usually do is I take a threshold of 6 millimeter mercury mean gradient. So if the mean gradient across the prosthetic mitral valve is more than 6 millimeter mercury, then I start thinking of problems of the mitral valve. So the first is look at 2D, and my threshold is mean gradient that is more than 6 millimeter mercury. So if you have a mean gradient that is more than 6 millimeter mercury across the mitral valve, so what you do is you look at other parameters. So the three parameters that is the most important when you're looking at mitral valve is, okay, after the mean gradient. So number one is the pressure half time. Okay. Number two is the E velocity. So what is the E velocity? When you put the CW Doppler across the mitral valve, so the E velocity is the early diastolic velocity. If it's more than 1.9, so that might suggest obstruction. And another one is dimensionless index that is more than 2.2. Dimensionless index for prosthetic mitral valve is different from prosthetic aortic valve. For prosthetic mitral valve, it is a VTI of the mitral valve over VTI of LVOT. Okay, I tell you one more time. The dimensionless index is the VTI of the mitral valve over the VTI of the left ventricular outflow tract. So you look at the DVI. So the three number that I would like you to remember to suggest some true obstruction is DVI that is more than 2.2, E velocity that is more than 1.9 meter per second, and pressure half time that is more than 130 millisecond. Okay, so just remember these three numbers. So mean gradient that is more than 6, then you remember the three number 1.9, 2.2, and 130 millisecond. So if they say when we talk about mitral valve, in order to determine the type, so whether this is obstruction, whether this is regurgitation, whether this is patient prosthetic mismatch, whether this is high flow, one of the way recommended by ASC guideline is by Gestalt. What I mean by Gestalt is there is no algorithm, but you look at the entirety of all these parameters. So if most of the parameters is over the threshold that I tell you, so this is most likely to be true obstruction. So that's one. Though there's also another one, which is an algorithm. So this is called the Blauet Miller algorithm that I will show you a little bit later. This algorithm is a little bit more familiar because we just look at the algorithm and try to see what is the type of dysfunction. I just wanted to start first for calculation of valve area. So remember when we do aortic valve, we use continuity equation. So whatever that go into the LVOT is the same that come out into the aortic valve. Okay, but we cannot do that for the mitral valve. Why we cannot do that for the mitral valve? Number one is we cannot do any geometrical assumption of the flow into the mitral valve because the flow into the LVOT shaped like a cylinder. But flow into mitral valve is very difficult to predict. That's number one. Number two is it's difficult to precisely pinpoint the velocity that we are measuring. Okay, so we cannot use the same concept as what we use for aortic valve. Remember that the pressure half time that we use to calculate area is only valid for native rheumatic mitral valve disease, rheumatic mitral stenosis. So the equation that we derive i.e. mitral valve area is equal to 220 divided by pressure half time. That is only for native mitral valve because of rheumatic mitral stenosis. So you cannot use it for prosthetic mitral valve. So you never use pressure half time to calculate area in prosthetic mitral valve. Okay, it can be a number to suggest that there is a true obstruction, but it cannot be something that you use to calculate valve area. However, we can also use continuity equation for the mitral valve. But the difference with the aortic valve is, rather than using, like in aortic valve, you use what come into the LVOT is the same as what come out of the aortic valve. For mitral valve, you have to do in between two valves. Okay, so what goes in the mitral valve is the same as what goes out the aortic valve. Okay, the continuity equation is between the two valves. The problem with this approach is if any of the valve have more than mild regurgitation, so if let's say you have more than mild aortic regurgitation or more than mild mitral regurgitation, you cannot use this equation. Okay, so in that situation, the only other way to calculate mitral valve area is to use PISA. Remember that we use PISA for our mitral regurgitation. If you use transesophageal echocardiogram, we can actually also do PISA for mitral stenosis. If you do PISA, then it's okay. It doesn't matter if there is concomitant mitral regurgitation. So how do we do the continuity equation? The first way is like this. So this is your LVOT, okay? And this is how to calculate stroke volume across the LVOT. So remember that in the absence of more than mild regurgitation, whatever come out of the LVOT is the same as whatever come into the mitral valve, okay? So you put your PW of the LVOT, you calculate the stroke volume, it should be the same as the one that is going into the mitral valve, but this must be CW. Why CW? Because you wanted to know the highest velocity where the orifice is the smallest. If you change this into equation, you can see that pi r squared times LVOT VTI, okay, which is the LVOT stroke volume, is equal to MV effective orifice area times the MV VTI. So you do your MV VTI. So just rearrange the equation, you get your mitral valve effective orifice area is equivalent to pi r squared times LVOT VTI over mitral valve VTI. So you get your mitral valve effective orifice area. So this is the easiest way to do it, and that is the most common way to do it. Now, if you have more than mild regurgitation in either of the valve, what you can do is you can do PISA. And the way you do PISA is exactly the same as how you do in mitral regurgitation. But normally this is not feasible when you do transthoracic echocardiogram. Okay, so I just wanted to show you an example of PISA. So why do we do PISA? So we do PISA because we wanted some way to have a geometrical assumption, okay, that we can do with LVOT. So we cannot do with mitral valve. So what we do is, so this is a mitral valve, and this is the flow across mitral valve. So in order to have something that we can have a geometrical assumption, we change the arising velocity, okay? So usually we lower the arising velocity on the direction of the flow. So you can see a hemisphere here. So why do you want to see the hemisphere? Because you want a geometrical assumption. Because you know what is the surface area of hemisphere, that is 2 pi r squared. Okay, so you know that surface area of hemisphere is 2 pi r squared. So in PISA, we are not looking at flow, but we're looking at flow rate. So the flow rate that go into the mitral valve is the same as the flow rate that go outwards out the mitral valve. So the one that goes inside is 2 pi r squared times the arising velocity. So that is the one that is going into the mitral valve, okay? 2 pi r squared times arising velocity, right? The one that coming out of the mitral valve is effective orifice area times the mitral stenosis max velocity times mitral stenosis max velocity. So you rearrange the equation. Your effective orifice area is equal to 2 pi r squared times arising velocity. Remember in the exam, most of the time they won't state what is the arising velocity. They wanted you to know that you can actually look at the arising velocity on the picture that they provide you. Remember that you use all the symbol in centimeter. Okay, change everything to centimeter. right? So then you can get your effective orifice area. So there's two ways. One is continuity equation between two valves. The other one is by using PISA. So this is the same as our aortic valve. So I think repetition is very good. So whenever you see a prosthetic valve that you suspect of dysfunction, what is the type of dysfunction? Are we dealing with obstruction? Are we dealing with regurgitation? Are we dealing with mixed obstruction and regurgitation? So unfortunately, all the current algorithm does not provide for mixed diagnosis. Or are we dealing with patient prosthetic mismatch? Okay, once we get that, of course, we look at the echocardiogram, then we now want to know what is the mechanism of dysfunction. So is it structural valve degeneration? Is it thrombosis, be it mechanical or prosthetic? Is it infective endocarditis, or is it patient prosthetic mismatch? So the type and also the mechanism of dysfunction. Now, there is advantage when you look at assessing prosthetic mitral valve compared to assessing prosthetic aortic valve. In transthoracic echo, in mitral valve, the leaflet is slightly easier to interrogate compared to the aortic valve. Now, the real advantage is when you use transesophageal echocardiogram. So remember, when we put in a transesophageal probe, the probe is actually just at the back of the left atrium. So it's just adjacent to the mitral valve. So the picture is very, very clear. Even more added value is when we add 3D transesophageal echocardiogram. So this is now routine. So mitral valve 3D from TEE is very beautiful. And oftentimes when we have issues in terms of identifying pathology in 2D TEE, we can do it very simply and straightforward in 3D TEE. So for example, I can say that the defect is probably in 2 o'clock. The flail is on the P3 leaflet. So that is the level of accuracy that we can give to the surgeon or to the reader. So when we see prosthetic valve and the mean gradient is more than 6 millimeter mercury, and we look at the other parameters, so one way to see whether they have that dysfunction is because of true obstruction is to look at the parameter. And remember the three number that I wanted you to remember. Number one, peak velocity that is more than 1.9. Number two, dimensionless index that is more than 2.2. And number three, pressure half time that is more than 130. So if let's say your patient have all these parameters, they fulfill all these parameters, so it's likely to be a true obstruction. Okay, so there is no hard and fast rule. I cannot say whether 2 or 3. So the more it fulfill, the better your confidence is that it is a true obstruction. Okay, and if you notice, I didn't emphasis on effective orifice area because I think that if you emphasize on effective orifice area early, you might get confused because most of this valve, the effective orifice area is very small to start with. Now, this is the algorithm that I tell you. So Blauet Miller, this is actually a cardiologist in Mayo Clinic. So I'm actually working with them at the moment to update this algorithm and also the algorithm for prosthetic aortic valve. Okay, so if you look at this algorithm, once your mean gradient is more than 6 millimeter mercury, okay, so it's actually quite simple. Look at your pressure half time. So that is the most important thing in this algorithm. So if your pressure half time is more than 130 milliseconds, straight away you can say the patient have obstruction. Okay, and that's it. You can stop there. Now, if your pressure half time is less than 130 milliseconds, now the problem with mitral valve prosthetic is you have to depend whether this is metallic or is this a porcine valve or is it a pericardial valve, because the TVI ratio is different for each of those. Okay, so this is for mechanical valve, right? So if your pressure half time is less than 130 milliseconds, but your TVI ratio, which is the ratio of the mitral valve VTI over LVOT VTI more than 2.6, you are dealing with a pathologic regurgitation. If it's less than 2.8, you do your effective orifice area index. If it's less than 1.2, notice that the threshold for mitral is 1.2. That is patient prosthetic mismatch. If it's more than 1.2 centimeters squared per meter squared, then it's something to do with high flow. Okay, so this is the algorithm. So the first thing that I showed you before, so this is what ASE guideline show. This is algorithm that is proposed by Blauet and Miller. You can use both. Okay. So I give you an example of cases. Okay, this is a continuation of yesterday. So yesterday we do prosthetic, now we do Microbuff. So for those of you who have never seen a single tilting disc, so I show you a single tilting disc now. So this is a Bioprosthetic single tilting disc Microbuff. So this is a Mayo format. So in Mayo format, the left ventricle is on the left part of the screen. Okay, so this is actually the single tilting disc. You can see that, right? So you can see a single tilting disc. Okay, right? So I just play again. So you see that, right? For those of you who've never seen one. Okay, so this is a parasternal long axis view. So it's quite difficult actually to tell and to differentiate in this view whether this is a single tilting or bi-reflect. Okay, but the assessment is the same. Okay, so this is actually the continuous wave across the mitral valve. How do I know this is continuous wave? It is totally white. Okay, so this is not a pulse wave Doppler. So if you look at the gradient, you can see that the gradient across the mitral valve is 3.34 millimeter mercury. So that is actually lower than 6 millimeter mercury. So just looking at the mean gradient across the mitral valve, I already know that this is a normally functioning valve. Furthermore, look at the maximum E velocity. So this is E velocity and that is E velocity. You can see that it's actually 1.6, less than 1.9 meter per second. So looking at the two-chamber view, so you can see in two-chamber view, the problem with prosthetic mitral valve is this shadowing here. Okay, so this shadowing here. So sometimes the regurgitation can be hidden behind the shadow inside the left atrium. Okay, so from here you can see that there is no regurgitation, but sometimes there can be regurgitation and you cannot see it. So this is the LVOT VTI. All right, so we want to see our dimensionless index, which is mitral valve VTI over LVOT VTI. So when you look at this patient, okay, we can summarize that this patient have a normal functioning single tilting disc mechanical valve. How do I know it is normally functioning? Because the mean gradient is less than 6. It is only 4 millimeter mercury. So normally you can stop there. However, if you want reassurance, you can see that the E velocity is 1.7. So it is less than 1.9. You can see that the dimensionless index is 1.6. It is less than 2.2. You can also see that the pressure half time is short, 113, less than 130. So this is all our reassuring parameters. Now, if you wanted to use an alternative algorithm, if you look at the Blauet Miller algorithm, you also will see that this is actually just a normal, fully functioning metallic valve. Okay. So let's look at our second case. So the first one is a single tilting disc. So let's look at our second case. So the second case is a ball and cage valve. So we no longer put in ball and cage valve nowadays. Now, however, we will see it. Why? Because ball and cage valve is a very durable valve. Okay, it lasts a long time. So this is a ball and cage valve. Okay, so what happened is when you see the ball moving towards the apex, so that is its opening. Okay, when it go down, it is closing. So going up is opening, going down is closing. Okay, so this is ball and cage valve. Okay, ball and cage valve here. So this is a parasternal long axis view of a ball and cage valve. So again, it's difficult to see and tell with certainty that this is a ball and cage valve. All right. So this is a continuous wave Doppler across this ball and cage valve. So now we have to explain, okay, for aortic, it is more than 3 meters per second, but for mitral valve, we take mean gradient, and you can see that the mean gradient go up to 9 millimeter mercury. So that is abnormal. So we have to explain why is it more than 6 millimeter mercury. Another thing that you can see is abnormal is also the Vmax. So the Vmax is actually the E velocity. You can see the E is 2.6. 2.6, so that is abnormal. Remember that I tell you the threshold is 1.9. What about the dimensionless index? So in this patient, the dimensionless index is 2.2, so just on the dot of that threshold. So what are we dealing with here? When we look at pressure half time is 75 milliseconds. So for those of you who all just come in, I ask people to remember 4 numbers. Okay, mean gradient that is more than 6 millimeter mercury need explanation. And the 3 number that you need to remember in terms of the parameters is, this is abnormal parameters, E velocity that is more than 1.9, dimensionless index, which is MV VTI over LVOT VTI that is more than 2.2, and pressure half time that is less than 130 milliseconds. Okay, sorry, more than 130 milliseconds. So in this patient, if you look at this is two-chamber view, you can see there is mild regurgitation there. Okay, usually mild regurgitation, I don't really worry about. So the valve area, if you look by continuity equation, so whatever come into the mitral valve is the same as what going out of the aortic valve is 1.55 centimeters squared. The body surface area is 1.72 meters squared. So when this patient, okay, why the patient have high gradient? So this is patient prosthetic mismatch, but on the mitral position. So this patient have a ball and cage mitral prosthesis. The mean gradient across the mitral valve is 8 millimeter mercury, and we need to explain why is it more than 6. However, the pressure half time is 75 milliseconds. If it's obstruction, it should be more than 130 milliseconds. The dimensionless index is on the dot, 2.2. That the effective orifice area index is abnormal. Okay, normal is more than 1.2. This is 0.91. Now, if you were to plug into the Blauet Miller algorithm, you can see that this patient has mean gradient that is more than 6. However, you can see that the pressure half time is less than 130 milliseconds. If you look at dimensionless index, it is 2.2. So that is where we go. And when we look at the effective orifice area, it is 0.91 centimeters squared per meter squared. So this is patient with mitral valve that having patient prosthetic mismatch. So I've shown you a normal valve, and I also show you patient prosthetic mismatch for mitral valve. So this case, so I've shown you single tilting disc. So this is bileaflet valve. Okay, so bileaflet valve is usually, I think, St. Jude bileaflet valve. So remember, I told you there are 2 major orifice and 1 minor orifice. Okay. So this is how bileaflet valve look in parasternal long axis view. So this is bileaflet valve of the mitral valve. Okay, so look at the flow across the mitral valve. Remember that prosthetic valve by definition is slightly stenotic. So there is always what seems like a turbulent flow across the mitral valve. There can also be a little bit of regurgitation, what we call as washing jet. So why the patient have washing jet? This is to prevent the formation of thrombus. Okay. So again, this is a Mayo format. So there's a left ventricle. So that is a bileaflet. So if you notice from what I show you, it is very difficult to differentiate the type of mechanical valve just from looking at it. Okay, sometimes you can, but most of the time you cannot. So don't worry. So because in terms of the assessment, it is the same. So this is again 2-chamber view across that bileaflet mitral valve. So if you look at this patient, okay, so you can see that the pressure half time is more than 130 milliseconds. Okay, so you worry. Once the pressure half time is more than 130 milliseconds, you get worried. So remember, you have to ignore mitral valve area by pressure half time, because you should never use pressure half time to calculate mitral valve area in prosthetic valve. So that is your pressure half time. So that is worrying. Okay. Now, if you look at the E velocity, the E velocity is way more than 1.9, more than 3. So that is also very worrying there. So this is the max velocity. You can see that the max velocity is 3. So you get the average. And you can see that the mean gradient is 20, way above 6 millimeter mercury. So what is this? So it is obstruction, is this regurgitation, is this patient prosthetic mismatch? Okay. So this, if you look at all parameters, this is actually a true obstruction. So how do I know it is a true obstruction? So let's go back. So the mean gradient is very high at 20. So we have to explain why the mean gradient is very high. The E velocity is very high, 3.2. Remember, the threshold is 1.9 to start thinking of true obstruction. The pressure half time is 220, way higher than 130. No, so from the algorithm, even without other parameters, we know already that this is a true prosthetic mitral valve obstruction. The valve area by continuity equation is 0.97. Okay, and when you look at the valve just now, once you decide the type of dysfunction, you also want to know what is the mechanism. So the patient have obstruction, but why? Is this because of structural valve degeneration? So structural valve degeneration, you will see calcification, it will be very, very bright. Okay, so in this patient, it's most likely is structural valve degeneration. But if you want to know for sure, you might have to do TE, or sometimes you might go for surgery and look at the pathological specimen. So if you use the Blauet Miller algorithm, So you see that that patient, the pressure half time is way more than 130 milliseconds, straight away go there, and it is pathologic obstruction. You can see it's very simple when you're dealing with obstruction. Just look at the pressure half time, okay? So that is metallic valve. Let's look at the bioprosthetic valve. Okay, remember bioprosthetic valve? If you remember what I told you in the talk before, it can either be porcine or pericardial. Okay, so Medtronic valve, the Hancock valve is a porcine valve. So this is the bioprosthetic valve. So the difference between bioprosthetic valve and mechanical valve, when you look at transthoracic echocardiogram, is the absence of shadowing from the leaflet. Okay, you can have shadow, so you can see that that is the stent there. Okay, so that is the stent, but the leaflet usually you don't see shadow. You see shadow from the metallic disc. But in patient with bioprosthetic, you don't have metallic disc, so you don't see the shadowing in the left atrium. So usually bioprosthetic valve has 3 leaflet. Okay, it doesn't matter where it is, it have 3 leaflet. So even though it is mitral valve, you remember that 90 mitral valve got 2, anterior and posterior, but bioprosthetic always got 3 leaflet. Okay. So if you look at the flow across the mitral valve, so everything looks okay. I didn't see any turbulent flow across the mitral valve. So this is a continuous wave Doppler across the mitral valve. And you can see that the max velocity is 2.4 meter per second, but the mean gradient is less than 6 millimeter mercury. So remember, whenever I see a mean gradient, just like aortic valve, that is less than 6 millimeter mercury, I usually will say that the valve is normal, especially if the appearance is also normal. Okay, so usually I don't go forward. Now, because 5.8 is very near to 6, I also look at other parameters. I also see that the pressure half time is short, 80 milliseconds. You remember, we start worries when the pressure half time is more than 130 milliseconds. The dimensionless index is also not high. It is 1.7. So all the parameters further reassure me. So even though the mean gradient is borderline, that is actually just a normal bioprosthetic mitral valve. So for those of you who missed the previous ball and cage, so I show you another ball and cage mitral valve replacement. Okay, so this is another ball and cage. So if you look at parasternal long axis view, I mean, if you just look at this, there's no way I can tell whether this is ball and cage or bileaflet or single tilting disc. Okay, so you look at the flow across the mitral valve. Okay, so remember the shadowing from the metallic disc might cause the regurgitation to be obscure. Okay, so look at this again. So this is across the across the ball and cage mitral valve. Remember, when this go up towards the apex, the valve is opening. When it goes down, the valve is closing. Okay, so even from here, you can see that there is no obvious regurgitation. Okay, just wanted to show you. Okay, so this is a zoom view. You can see that the ball and cage go up, go down, go up, go down. So going up is open, going down is closed. Okay, so for those of you who never see a ball and cage valve. So if you look at the parameters, you can see that the mean gradient is extremely high. Okay, it's 14.55 millimeter mercury. Look at the max velocity is 2.6 meter per second. So this is the importance of understanding the parameters. Okay, so even though looking at the valve seems to be working normally. Okay, even looking at the color flow, you don't see any obvious thing that you worry about. However, something is wrong. That's why the mean gradient is very, very high. So why is the mean gradient very high in this situation? So when we look at the pressure half time, it is 140 milliseconds. So remember, anything above 130 milliseconds, you start to worry. So this patient actually have through obstruction. The mean gradient is 15. Anything that is more than 6 need to be explained. The E velocity is way up at 2.7. So the clincher is pressure half time, which is 140 milliseconds. So if you follow my thought process, you know that once you know what is the type of dysfunction, then you want to ask yourself why the patient have obstruction. Structural valve degeneration, thrombosis, patient prosthetic mismatch, infective endocarditis. So that is your differential diagnosis. So this patient goes straight away to that part algorithm. So this is the Blauet Miller algorithm. So this is a pathologic obstruction. Okay. Remember, if you want to use Blauet Miller algorithm, there is 3 algorithms for mitral prosthesis. So the mechanical and the porcine and the pericardial mitral valve is different. So aortic valve is simple, all are the same. But for mitral valve, it is slightly different. The difference not on the pressure half time, but on the dimensionless index. So this is patient with pathologic obstruction that have ball and cage mitral valve. So I hope by now you have understand how do we approach prosthetic mitral valve. Just to tell you again, whenever the gradient is more than 6 millimeter mercury, you have to explain why the gradient is more than 6 millimeter mercury. Okay, you use combination. So if you want to use the ASE guideline, the ASE guideline does not give algorithm. So you have to combine all the parameters. So what suggests through obstruction is the 3 number that I asked you to remember: E that is more than 1.9, dimensionless index that is more than 2.2, and also pressure half time that is more than 130 milliseconds. Okay, if you want to use the Blauet Miller algorithm, is also okay. And in Blauet Miller algorithm, the pressure half time is very important. And then after that, you look at the dimensionless index to see whether you are dealing with regurgitation or patient prosthetic mismatch. Okay, so that is it in terms of aortic valve and mitral valve, and also assessing dysfunction. So what I wanted to show you after this is, we wanted to go deeper into the mechanism. So why the patient having dysfunction? So one of the most important causes is dysfunction is valve thrombosis. And this we are very familiar when we are dealing with mechanical valve. However, we know now that bioprosthetic valve also can thrombose, okay? But how do we see thrombosed bioprosthetic valve? So if you look at patient and you assess someone with prosthetic valve, whenever you see that the gradient increase more than 50%, so let's say they have mitral valve bioprosthesis, when you first see them, the gradient is 4 millimeter mercury. Okay, but you see them in 6 months time, it has become 10 millimeter mercury. So that's one of the clue. The other clue is you see thickening of the leaflet, but you don't see calcification. So if you see thickening and not calcification, that is most likely to be thrombus. And when you do transesophageal echocardiogram, I think my personal experience, about 70 to 80% of the time, you can tell from TEE whether you're dealing with thrombus or calcification, structural valve degeneration. If you cannot tell, one of the way to do it is to anticoagulate the patient and to see whether they respond to anticoagulation. For bioprosthetic valve thrombosis, it is very easy. The treatment is warfarin. Okay. So this is a transesophageal echocardiogram example of a bioprosthetic valve thrombosis. So if you look here, so this is a bioprosthetic mitral valve. So you look at this leaflet here. So one of the leaflet is thickened. Okay. However, this leaflet is not calcified. I know it appears bright, but if you look at the brightness, it's the same as the heart tissue. So this is not calcification. So this is an example of bioprosthetic valve thrombosis on the mitral valve. So that is the left atrial appendage there. Okay. So this is the flow across the mitral valve. So for those of you who look at this flow, so if I stop somewhere here, so you can see that I can even do PISA, even in patient with mitral stenosis. So I like to do PISA if they say the patient have significant regurgitation. So the flow rate going into the mitral valve, so 2 pi r squared times a lysing velocity is equal to the flow outside, which is effective orifice area times the max velocity of the mitral valve. Okay, so right, so you can see the PISA there, right? So the 3D view is not clear. I just wanted to show you, and I think you can appreciate that it is actually tri-leaflet. So bioprosthetic valve is tri-leaflet. So this picture is not clear because of the resolution, but you can imagine that how good it is in terms of understanding the pathology that affect the valve. I will show you a better example after this. So when you look at this patient, so we can see that the mean gradient across the valve is 15 millimeter mercury. So this is a true obstruction because of bioprosthetic valve thrombosis, and just show you that thrombosis also can cause significant obstruction. Okay, so that example of bioprosthetic valve obstruction secondary to thrombosis. Now, I wanted you all to be familiar with this procedure called the ROS procedure, because I think no one get a proper explanation unless they do pediatric cardiology. So what is ROS procedure? So it's very important for you to know. So ROS procedure is actually an alternative to aortic valve replacement in a young adult. Okay, so why is ROS procedure one of good alternative? So the reason it is a good alternative is you preserve your human valve. So what do we do in ROS procedure? So what happened in ROS procedure is this. So let's say that you are born with stenosis, or maybe you have problem with your aortic valve when you are young. Okay, so maybe your aortic valve is stenosis or regurgitation. Okay, so what happened in ROS procedure is they take the whole of the pulmonary root. So this is the pulmonary root that they take out. Okay, so they take out the diseased aortic root with the aortic valve. All right, so they detach the coronary, then they put this pulmonary root into the aortic root. Okay, so you replace your diseased aortic valve with your pulmonary valve and pulmonary root. Okay, now you will ask me, so what happened in this empty space here? So in this empty space there, you put a homograph. So what is a homograph? So homograph is a root plus conduit plus valve. It is a root plus valve that come from cadaver. Okay, that come from cadaver. So this patient will end up like this. So this is the old pulmonary root that is now in the aorta, and this is the homograph. So the advantage of this procedure is you do not have any prosthetic material in you. No bioprosthetic, no mechanical. So you overcome the problem with structural valve degeneration, thrombosis, bleeding. Okay, that is the advantage. In a very experienced hands, the patient with ROS appear to live forever. Okay, the outcome appear to be very, very good. But there is a catch. The catch is it only happen in few select center. This procedure is difficult. The surgeon must be very, very skillful, and not all surgeon can do it. Okay, very minority of surgeon can do it. So that is the disadvantage of this procedure. Another disadvantage is this homograph can sometimes give problem and degenerate, and you have to put a conduit and replace it. Okay, so if you have a very experienced surgeons, and to be honest, I'm not sure even if in IJN we have that. I think probably we have. Then you can have that as an option. So for example, if I were to have an aortic valve problem, I will go to the surgeon that is most experienced with ROS, and I will choose to have ROS procedure rather than have a valve replacement. So once you do this, the problem is when you look at echocardiogram, you cannot tell the difference. Okay, you cannot say the patient have undergone ROS procedure. So what you need to do in this situation is to read the notes. So if you look at the echocardiogram, so this is the neo-aortic root. Okay, why do we call neo-aortic root? Because this is actually pulmonary root that has come here. So whenever it have changed places, we give name based on what connected to. So this is a neo-aortic root. If you look at the neo-aortic root, you cannot tell the difference between this neo-aortic root and a normal aortic valve. Okay. So look at the leaflet tips. There's no problem there. Okay. Now, so there's a little bit of regurgitation. Okay. So now we are looking at the pulmonary homograph. So this is aorta short axis view. So this is looking at the pulmonary homograph here. So what I wanted to assess is the pulmonary homograph is working well. Okay. So when you look at the color, so what do you think? Okay. So there is a backflow through that pulmonary valve. Okay. And there's a little bit of stenosis. How severe is that? So we put a continuous wave Doppler. Look at this, okay? Even though this is not a pulmonary lecture, but whenever you put a continuous wave Doppler across the pulmonary valve, and you can see a triangular shape like this that end way before diastole, so this is severe pulmonary regurgitation. Why it ends very early? Because your right ventricular end diastolic pressure is very high. Another thing that is important to see, you look at this forward flow during atrial contraction. So this forward flow means that at the end of diastole, at the end of diastole, when the atrial contract, because the RV pressure is so high, that contraction of the atrial push the blood from the right ventricle to the pulmonary artery even before the start of systole. Okay. So this, and when you look at the forward flow, you can see that the velocity is quite high, 2.6. So this patient have mild stenosis of the homograph and severe regurgitation. Now, this is something that I think a lot of us don't realize. Okay, now because there is a risk of bioprosthetic valve thrombosis, and the surgeon have become aware that even in bioprosthetic valve, you need to anticoagulate the patient. So look at this guideline from ACC/ASA. Okay, if you do TAVR valve, okay, so after the procedure, either you give dual antiplatelet for 3 to 6 months, or you give warfarin plus aspirin for 3 to 6 months. Then after that, you give aspirin. Okay. What about you have bioprosthetic aortic valve replacement? Okay. The suggestion is to give aspirin 75 to 100 milligram daily for 3 to 6 months. Okay. However, they ask you to consider to add also warfarin for 3 to 6 months. Okay. For mitral valve, because have higher risk of thrombosis, you can see that they ask you straight away to give warfarin plus aspirin for 3 to 6 months. All right. This is transcatheter mitral valve replacement. So this one I do not want to touch because this is not widespread yet. I don't think we do it in Malaysia yet. Now, if you look at all this and you look at the risk of bioprosthetic valve thrombosis, I think I'd like to suggest something. Okay. Why don't in the patient that is not contraindicated in all bioprosthetic valve, be it TAVR, SAVR, aortic valve replacement or mitral valve replacement, we just give them warfarin for 6 months and after that continue with aspirin just to be safe. What is the treatment for thrombus? Now, if the thrombus happen on mechanical valve, so what you do is usually thrombolysis. Okay, so nowadays thrombolysis is the main treatment for thrombosis. Now, if the thrombosis happen on bioprosthetic valve, if the patient is hemodynamically stable, you can actually give warfarin and get the warfarin to a target range of 2.5 to 3.5, and usually the patient will recover. In fact, there is one patient that we do TEE and we give lysis. We can see the thrombus disappear when we're doing the transesophageal echocardiogram. What's the virtue of TE and looking at the mitral valve? So it's extremely useful because the probe is directly behind the esophagus. So you can see the leaflet motion, you can see perforation, tear, thrombus, and vegetation quite clearly. So I just wanted to show you a few examples before we finish, okay? Just to show you the versatility of transesophageal echocardiogram. So this is a patient with severe bioprosthetic mitral valve regurgitation, okay? When you do transthoracic echocardiogram, okay, you can see severe mitral valve regurgitation, all right? But you wanted to know exactly what is happening to the mitral valve. It's difficult to see just from transthoracic echocardiogram here. So when we do a transesophageal echocardiogram, so this is the bioprosthetic mitral valve, you can see the hole at the side here, okay? So this is mitral valve dehiscent. You can see slight rocking of the mitral valve. So you can straight away tell that your patient actually have dehiscence. So dehiscence can be either due to structural valve degeneration or infective endocarditis. That's the dehiscence there. Now, the next patient also have high gradient across the mitral valve. When we do transthoracic echo and we look at the parameter, it suggests obstruction, okay? And we do TE, it shows thrombus of the bioprosthetic valve. And this thrombus cause obstruction to inflow, okay? Now, people like to ask how to differentiate vegetation and thrombus from echocardiogram. So the answer is without clinical contact, it is impossible. Why do I say it is impossible? Ask yourself, what is vegetation? So vegetation is actually thrombus plus infecting microorganism. Okay, so it is actually infected thrombus. So how can you differentiate thrombus and thrombus? Okay, so you have to get a clinical contact. However, if there is associated abscesses, fistula, or pseudoaneurysm, then of course it is more likely to be infective endocarditis. Okay, so look at this patient with a bioprosthetic mitral valve and look at this. You can see that the leaflet is thickened. However, it is not calcified. Okay, so remember when I tell you, hypoattenuating leaflet thickness, leaflet thickening, and RAM, restricted leaflet motion. Okay, you can see that mitral valve thrombosis there. Okay, and you can see the obstruction of flow across the mitral valve. So I show you another TEE showing dysfunctioning mitral prosthesis. So this patient have a rocking mitral bioprosthesis with perivalvular regurgitation. So in this case, I will show you how 3D TEE is extremely helpful in looking at the reason for dysfunction and pointing exactly at the site of dysfunction. So this is the bioprosthetic mitral valve. So from here doesn't look to be any problems, okay? But you can see probably there is a subtle rocking here, okay, on that side. So this is a lateral side. Now when you look at this transesophageal four-chamber view mid-esophagus, so LV, RV, LA, RA, you can see there is regurgitation way on the lateral side there. Okay, there's regurgitation flow here. But just from 2D echo, it is very difficult to pinpoint where exactly is the regurgitation. Now, once we do a 3D TEE, so this is the bioprosthetic mitral valve, you can see 3 leaflet moving. So looking at here, if you're looking at the side, you can see there is a little bit of dark line from here to here. Okay, I just play again and see whether you can see dark line from here to here, dark shadow. Now, if you cannot see it, once we put color, so I put color, look at that. You can see there is regurgitation flow at the shadow that I tell you. Okay, so I can tell surgeon straight away, okay, that there is defect from, but which o'clock is this? From 9 o'clock to 12 o'clock of the bioprosthetic medulla. So that's the deficient there. So I can pinpoint the deficiency. So that is the advantage of 3D transesophageal echocardiogram. Our next case illustrates the role of TTE in unmasking mitral regurgitation. Sometimes if we have very eccentric mitral regurgitation, it cannot be detected at all in transthoracic echocardiogram. Always suspect eccentric MR in TTE where there is unexplained increase in gradient, yet the valve leaflet seems to be opening normally. If you see the pressure half time is short, but the DVI is high, think about regurgitation. So look at this patient. So this patient have bioprosthetic mitral valve. It looks a little bit calcified, isn't it? And also thickened. So if there is a problem, this is most likely to be structural valve degeneration. Okay. Now, if we put color, okay, this is two-chamber view. I mean, there is no regurgitation at all. So you cannot see any regurgitation at all. The only clue that we are dealing with regurgitation is this patient have elevated gradient across the mitral valve and the DVI is high, okay, more than 3. So there's something wrong, okay? Now, so even when we zoom, we cannot see anything, right? So we go to transesophageal echocardiogram and lo and behold, so this is the TE four-chamber view, LV, RV, LA, and RA. So you cannot see anything, right? This is two-chamber view, right? Can you see anything? Can you see any problem for those of you with sharp eyes? So remember, when you do two-chamber view, so what is that? That is left circumflex. So that is coronary sinus, okay? Whenever you see left atrial appendage in TE, that is your lateral marker, okay? So that is lateral, that is medial. So what is this there? Okay? Look at the hole here at the medial side. So there's a hole there, okay? That we cannot even see in transthoracic echocardiogram. If I give you color, you can see the color swirling in the left atrium. What you don't see at all in the transthoracic echo, you see it swirling like that inside the left atrium there, okay? So obviously this is a severe bioprosthetic mitral regurgitation. You can see that again, okay? Now, for those of you who do TE, when you want to say someone have severe MR, you usually pulse inside the pulmonary vein and you want to look for systolic reversal. Remember, don't pulse in the pulmonary vein in which the flow is going into that pulmonary vein. If you pulse there, for sure you can see systolic reversal. That doesn't count. You have to go to the pulmonary vein that is not impinged by the flow of the jet of the regurgitation. Okay. The next case is example of bioprosthetic mitral valve obstruction in transesophageal echocardiogram. This illustrates complication that give us clue to the reason of obstruction. As you can see in the next case, there is pseudo aneurysm in the atrial wall with flow to and fro into the pseudo aneurysm. So you see obstruction and you cannot tell what is the reason, but at the same time you see pseudo aneurysm and you see fistula and you see abscess. You are dealing with infective endocarditis. Okay, so look at this echocardiogram here. So this is, you can see this very soft thickening. Okay, this can either be thrombus or it can be vegetation depending on clinical situation. However, in this case, okay, if you look at the next picture here, all right, still, all right, it looks like vegetation or thrombus, okay? See that on the Microbuff, look like vegetation and thrombus. But look at this picture here. So that is the left ventricle, that is the left atrium. So what is happening? So what is this cavity here? Okay, so there is cavity outside of the left atrium. And you can see flow going into the cavity, coming back to and fro. Okay, to and fro, going from cavity outside. That can only be pseudo aneurysm. What is the difference between pseudo aneurysm and aneurysm? In pseudo aneurysm, you do not have integrity of all the wall. Either all the wall is gone or some of the wall is gone. In aneurysm, all the wall is still intact. Okay. Right. So I show you again. So this is your pseudo aneurysm there. Right? So we're almost going to go to end this now. All right. So I just wanted to show you maybe 2 other cases. So our next case is patient with the case of periprosthetic regurgitation. Now, sometimes if the hole is not too big, you can try to close it by Amplatzer device if you have regurgitation. So in this case, it is not big enough to close the hole. Okay. So you look at this patient. So this is the bioprosthetic valve. Okay. So the regurgitation is at least somewhere here. So you can see 2 Amplatzer device here. Okay. Remember, Amplatzer device is actually just a circle. Okay. It's just one circle. But you look at here, you look like 8. So you can see circle at top and circle at the bottom. Circle at top and circle at the bottom. So the tick at the bottom is not a real circle. Okay. That is just an artifact. This is called a figure of 8 artifact from Amplatzer device. Okay. Now, if you look here, if I play here, you can see that there is regurgitation going at the side. So these are the Amplatzer 1, 2. Look at here. So if you look there, there is regurgitation there at the side there, okay, of that Amplatzer device. So this patient is unsuccessful. There's still regurgitation, so he needs to go for surgery, right? So this is just a color of the same patient. So 1 Amplatzer device, 2 Amplatzer device. That is the bioprosthetic mitral valve. What is that hole there? That is the left atrial appendage. Whenever you see a left atrial appendage, that is lateral part of the mitral valve. So this is a bonus case, okay? So we have talked aortic valve and mitral valve. So we haven't talked about tricuspid valve, but I give you one nice case of bioprosthetic tricuspid valve. Why is it a nice case? What I like about this case is the patient have perivalvular regurgitation. So the jet go into the eustachian valve, then the eustachian valve redirect into the interatrial septum. Remember or not, this happened when? This actually mimic what happened when we are in our embryological development. Remember in embryo, the eustachian valve actually direct the blood from the inferior vena cava into the fossa ovalis. So you can see here. So this is a bioprosthetic valve thrombosis. So that is the regurgitation. So that is your eustachian valve. So that is the bioprosthetic valve. That is the eustachian valve. That is the interatrial septum. So I play again. So look at the jet. Go into the eustachian valve to the interatrial septum. Jet from the periprosthetic tricuspid valve to the eustachian valve to the interatrial septum. Okay, I find it interesting. Okay, like it repeat back what happened in fetal life. So this is another example. This is the same patient, but different view. So again, you can see the S shape going from perivalvular into the interatrial septum. So this is just a 3D view, all right, and just showing you where the paravalvular leak come from. So I think this last case is just someone with structural valve degeneration across the mitral valve. So I don't think we need to belabor this one. So we have seen this one before. So lastly, even though I've said this over and over again, I just wanted to remind you again, because this is our last talk on prosthetic valve. You see a prosthetic valve, if let's say it's more than 3 meters per second in the aortic valve, more than 6 millimeter mercury in the mitral valve, think of what is the type of dysfunction. Is it obstruction? Is it regurgitation? It can be mixed, okay, but remember the algorithm have no place for mix. We will try to improve that. And either it is patient prosthetic mismatch. If you have dysfunction, what is the mechanism? Are we dealing with structural valve degeneration? Are we dealing with a valve thrombosis? Are we dealing with infective endocarditis, or are we dealing with patient prosthetic mismatch, right? So what is the take-home messages? So both bioprosthetic and mechanical valve has its own problem. Both confer the same survival disadvantage compared to normal population. It's the same, regardless of the valve position or even if it is dual valve replacement. Structural valve degeneration happens to both, but much commonly in bioprosthetic valve. Thrombosis occur more commonly in mechanical valve, but now increasingly recognized in bioprosthetic valve. Remember, thrombosis in mechanical valve is more dangerous than thrombosis in bioprosthetic valve. Whenever you see high gradient, it can be due to obstruction, regurgitation, mixed patient prosthetic mismatch, or pressure recovery that I've already explained to you before. And the mechanism can either be structural valve degeneration, thrombosis, infective endocarditis, or patient prosthetic mismatch. For aortic valve, we start to worry when the velocity is more than 3 meters per second. For mitral valve, when the mean gradient is more than 6. Treatment for bioprosthetic valve thrombosis is warfarin. For mechanical thrombosis, lytic therapy can be considered. Otherwise, you have to go for surgery. So in terms of the dosage, you can give 25 milligram TPA in 6 hours or 25 milligram in 25 hours. So in terms of the dosage, you have to find for yourself. So that's it. Stay tuned for our publication on the new algorithm. So I really thank you all for come and join me. Okay, so if you have any question, all right, please feel free to ask. Thank you very much.